And we'll be live in 3, 2, 1, and we are live.
And good afternoon, Dr. Deukmedjian at Deuk Spine Institute, Surgery Center Vieira. We're getting ready to perform our second surgery of the day. It is a Deuk laser disc repair, bilateral L3-4, left L5-S1. Our patient has had surgery before. She's had surgery with a big scar on her back. Huh? All right, I'm just talking to her. This is Dr. Deukmedjian. We're going to get started, okay? So our patient has really bad back pain, okay, and pain into both legs with numbness in her feet. And we know that the nerves going down from her back down to her legs, they're called nerve roots at L3-4, specifically the L3 and L4 nerve roots, are being pinched on both sides of the spine. So to effectively treat that, I have to go on both sides and unpinch them. And they're being pinched from herniated disc. The most common cause of spinal stenosis is herniated disc, period. The most common cause of lumbar or cervical spinal stenosis is herniated disc. So we're going to go treat the herniated disc. The herniated discs are, it's important to understand that because disc herniations are in the front of the spine, basically the front part of the spine, projecting backwards towards the nerve root. Whereas facet problems are in the back. Okay. We're going to get started. It's Dr. Deukmedjian. Are you okay? I'm going to give you some numbing medicine, all right? You won't like it. You'll feel a little poke and a burn, but just bear with me and lay still, and it'll get better in just a minute, okay? I apologize that it's uncomfortable. We're giving local, which every surgeon does in every surgery pretty much. Little poke. I know it's uncomfortable. Just bear with me for a moment while I numb things up, okay? I apologize. And then we'll need a second on the left side, which this is the left side. 9 cc's. All right, watch the needle. All right. So what I've done is I'm giving her some skin numbing medicine to make it more comfortable for her to do the surgery. And she's awake, so she will be awake for the beginning, and then we'll put her to sleep once we're ready to do the actual fixing the disc part. But to start things off, we need to get safely from here in the operating room down to the herniated disc, and that's what I am going to try to do right now. All right, let me know if it's uncomfortable, okay? Just say ouch, and then I'll give you more numbing medicine. All right. I apologize that we need you awake in the beginning. So I'm going to go for L3-4. Let's go south a little bit with the fluoro. Beautiful job, Jordan, of identifying that. I wouldn't go too far, just a little bit, just a ½ an inch. All right, that's fine. So you can see on the x-ray that there's the sacrum at the bottom. You want to point to the sacrum for us, Jordan? Sacrum is the tailbone, and then the first disc there above the sacrum is the L5-S1 disc, and then show us the L5 vertebral body. And now take a look at the L4-5. That's actually fused. She had surgery done by another doctor. He fused her without even putting a cage in. And you know, the problem is when you look at those bones, there's no curve between them, no curve backwards. We call that a flat back deformity, when it's just straight. So because of that, the disc above and below get extra stress, and that causes them to wear out. All right, shot. Let's get some numbing medicine. We're going to give her a little bit of local. Is Flynn not ready to graduate?
Yeah, I mean, he's coming next. I'm sorry, let me start with him.
That's all right. No, you stay for now.
Yeah, he's coming.
So we're providing some numbing medicine. And shot, I need to be a little bit more superior, higher. Superior means towards the head. Just relax. You're doing great. Okay? You're doing really good. And what I'm coming up against is the facet joint, which is full of arthritis. Shot. Where do you feel that? Give me an AP, please. So I'm actually, it looks like I'm passing through the facet joint with a needle, but that's not really what's happening because you can't pass through a bone with a needle. That's what you see on the lateral view, but on the AP, it's going to give us a better picture. All right, so I'm going to adjust everything and start a little bit more medial. Let's go back to the lateral, please. And lateral means a picture from the side. So we're using an X-ray machine called a fluoroscope. And fluoroscopes are used in hospitals and surgery centers by surgeons to do procedures that require navigation using an X-ray machine. Shot? You're doing great. Everything's okay. I know it's a little bit uncomfortable right now for you. I apologize. But I promise you everything's going very well. Are you comfy? All right. Are you breathing okay? All right. Just relax. Everything's good. We're going to be done probably in 10 minutes. We'll be able to put you to sleep, all right? Shot. All right, AP. So I'm approaching the herniation at L3-4 with the tip of the needle. And remember, we have to go on both sides because she has leg pain on both sides at L3-4, coming from L3-4. All right, that's much better. Let's go back to a lateral view. So I'm just sneaking around the facet. She's got a little bit of scoliosis. You can see that. The spine is twisted off to her right side, away from my needle, which is on the left. And you can never tell where you're supposed to be based on just one view. That's why you have to switch views. You go from front back to side. Where do you feel that? Yeah, that's your herniation we're at, okay? Good news is that pain will be gone when we're done. So one of the tricks to doing this type of surgery safely is you really should move your entry point more medial as you go up the spine. That's a pearl, very important pearl. Shot. You're doing great. Let me just get this done and we'll put you to sleep, okay? Shot. Shot. I want to be a little bit higher than I am. Let me give you some more numbing medicine. You're doing fantastic. Just give me a second. I'll give you some more medicine. So our patient needs to be awake so that they can help me navigate to where I need to go in the spine. I apologize. That was just some numbing medicine going in. I know it's uncomfortable. You're doing really good. And patients don't know what's going on really during the surgery unless they've watched quite a few of these. But I like to give them some encouragement if things are going well, just to make sure they know everything's okay. Because what they may be feeling and what they may be hearing are two different things. They may think, oh, there's a problem, but there's not a problem. Everything's okay. Unfortunately, there is pain, some discomfort with the beginning of this type of surgery when you're awake. Let me just go a little further and then we'll get an AP. And I can feel the needle passing the facet joint. But before we go any further, I want to verify my position on AP to make sure that I'm not too lateral, too far to the side, which I'm not. It's perfect. All right, and that first needle you can see went across midline. That's fine. That's good. I've got a good reach. So I'm going to be able to clean out the back of this disc very nicely. I'm very happy with that. All right, you can actually see the herniation. Can you see it? Jordan, can you show it to them? There's barely a faint outline. That's correct, a little curve there. It's like a half of a peach or something just sticking back there. So you really can see certain herniations on X-ray. And of course the size of the herniation, location, and then of course the amount of bone mineralization the patient has is important. All right, so basically if you have really fainter bones, it's easier to see. We're not going to go there.
No?
There's no way 3, 4, and 5, 1 are the same entry point. All right, you doing okay? We've got 2 spots identified well, and we're going to do the third one now, okay? And then we'll be able to put you to sleep shortly thereafter. All right, just let me know if you're feeling any discomfort, okay? I gave you some numbing medicine, but sometimes I have to stop and give more. All right, that's the iliac crest shot. So, could be a little bit higher. All right, shot. Take it easy, you're fine. All right, it may actually have to come through the same place. Shot. All right, just relax. You're doing fine. I'm going to give her a little more numbing medicine. You're doing good. I'll give you a little more numbing medicine, okay? This is the last one. And then we'll be ready to do your discograms and then put you to sleep, okay? So you're very brave. You're doing really good. Blood pressure good? Yep, it looks like it is. Okay. So L5-S1 is always the hardest to do. Barring any unforeseen circumstances. Shot. I've got to get this lined up perfectly with that disc space at L5-S1. Shot. 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 It's looking better. All right, that's the facet joint. We need to get around it. That's usually always the trouble at L5-S1, getting around the facet joint and the iliac crest. Let's go with an AP and see where we are. Either I'm too lateral or I'm too medial. It's one or the other. I don't know which one it is yet. I suspect they may be too lateral. Nope, too medial. All right, back to the lateral view. I'm actually hitting the medial part of the facet joint. You could see that, like right where the joint is, right where L5-S1 facet joint is. You see there's the L5 inferior facet and the S1 superior facet on the left side. And I'm just a little bit too medial. So I'm going to redirect. Just relax. You're doing really good. Don't tighten up, Sean. Try not to tighten up. Yeah, this is the hardest part of the surgery, I know. Sean. Beautiful. Just about there. Where do you feel that? In your back or down your leg? All right, we're just about done, I promise. AP. We should be right there. And she does have some shorter pedicle at L5, but there's also a little rotation at 5. Uh-huh. That's not bad. We're just passing that facet joint. Let's play with the arc just a small amount. 1 degree. That's better. I think maybe it's worse though. It's hard to tell. Huh, a little more that way. Let's try that. It's really hard to tell. Looking at the back of the vertebral body, that seems a little better. You okay? Where do you feel that? All right. You said foot?
Yeah.
Just relax. Sean, is it better? All right, so she's more rotated. We're going to have to come in more lateral. You may actually be able to get it from that other one. You know, from that incision. Let's try. Let me know if you feel any discomfort, okay? So we'll go ahead and make our incision. I'm going to try coming a little bit more lateral to L5-S1. Shot. For those of you wondering, this is always the longest, hardest part of the surgery. After you get past this, it's very easy to do the rest of the surgery. And it looks like we're on pretty good target. Shot. It's not bad. Where do you feel that? In the back? Yeah. All right. Back is okay. Shot. We're right where that bad disc is. Let's do an AP again. That's why it's uncomfortable. It's full of arthritis. It's not bad. Let's go back to a lateral. Thank you, Luis. So this is always the hardest level to reach, is the L5-S1 transforaminal approach. Everything else is much easier. So that's why it's taking us a little longer, but we want to get it just right. Has to be just perfect. So we're going to stay here until we get it just right. Where do you feel it? Huh? All right. Back and buttocks are fine. That's perfect. Still back? Where? Okay. Let's give it a minute. Try to lay still. Shot. Give me an AP. Once again, we use two views, at least. AP and lateral. Uh-huh. All right. Shot. Still pressure in the foot? Huh? Yeah. All right, we're almost done, I promise you. I've just got to get this one last part just right. Where do you feel it? All right. I'm going to come in a little bit lower than I was. See if we can make it a little better. Just relax, you're doing good. What is that? Messing with our view. Is that just the Ratek shot? All right. So right now the challenge is to navigate the foramen properly. I don't know if our WAG is off a little. It looks like our WAG may be off just a degree. Try it, because I'm seeing the top of the S1 pedicle and they're offset. Shot. I almost feel like that's worse. So it's very important that you look at the bones and line them up properly so that you know you're getting a true, I think that's better. Yeah, that's better. Let's try that. Let's try that. That looks good. It's important you get your fluoro right. If you don't, you're going to struggle. And you could end up being where you don't want to be. Doing all right? Huh? All right. Where? Okay, stop moving now. You're okay. I promise, you're all right. So I came in lower. Just relax for a minute. You're doing fine. Shot. So I'm in the disc. I'm just sneaking along the end plate. Give me an AP. You okay? No leg pain, right? That's good news. Shot. All right, good. You comfy? You tired of me torturing you back here? Are you ready to go to sleep? How much of your pain was back pain versus legs? Was the back pain more or was the leg pain more? Right, but what about your back pain? All right, so she has two discs we're going to be working on today. One is L5-S1. It's the bottom disc in the spine, the very last one at the bottom, just above the tailbone. Tailbone sits here, and that's the disc. And she has a tear on this left side with a small herniation. And then she has, at the L3-4 disc, can you see this? Diego?
Yes, we can see.
She has a herniation on both sides, one on the right and one on the left, and the nerves that are coming down are getting hit by that herniation. So, and that's what's causing some of her leg symptoms. Are you comfy? All right. Have you watched many of my surgeries done? No? You have? All right. How bad is that on a scale of 1 to 10? 10 being the worst pain of your life. How bad was it? What's the highest it went? It didn't go over a 7? Huh? All right, so 7 out of 10. Is that where you get your back pain typically, in that area? Yeah. All right. So yes, it was a 7 over 10. Personally, I thought it was worse than that, but that was L3-4. 7 over 10 concordant. All right. You okay? Is it better? All right. So there's still dye in there, okay, which has led doctors to understand discography a little better. It's not a chemical reaction to the discogram material. It's not a chemical reaction to the Omnipaque or saline, because it's still there at L3-4, but her pain's back to being gone, right? It's actually irritation. It's a pressure on like if you were, how bad is that on a scale of 1 to 10? How bad is that? 9? 9 over 10, okay? That was L5-S1. Is that where you get your back pain? Yeah. All right, so both of these discs were concordant. Okay, you get to go to sleep now. Go ahead and count from 1 to 100. When you wake up, we'll be done. You're welcome. Count out loud for us from 1 to 100. So for those of you joining us now, we just tested the two discs we're going to be repairing today, and the bottom one was more painful for her. She called it a 9 out of 10 when I activated it with the discogram material. And so that disc is probably causing more of her pain than the one above, which is L3-4. But the L3-4 is pinching the nerves worse. So the leg symptoms are coming mostly from L3-4. The back pain is coming more from L5-S1. We're going to fix both, so it should take care of the back pain and the leg symptoms. Folks, if you don't believe back pain can be cured, we've been curing it now literally for I've been curing it on my own since 2004 here at Deuk Spine. Huh?
L3-4 first?
Yeah. And we've cured back and neck pain either with fusions or with laser surgery, either one. But why go through a fusion if you don't need it? I mean, nobody really needs a fusion. You don't. If your doctor is recommending a fusion, it doesn't mean you need a fusion. It means that's all they know how to do. Okay? So if you're out there and you have a herniated disc or a bulging disc and you've got back or neck pain and your doctor's told you you don't need treatment, they're wrong. You do need treatment to get rid of your pain. Okay? You don't need treatment. Okay. What they mean to you when they say you don't need surgery is they're saying you're not going paralyzed. So from my criteria, a patient has to go paralyzed to need surgery. They're saying you don't meet their criteria. But the truth is that your pain's not going to go away unless you have a surgery on a herniated disc that's causing your pain, because surgery is the only thing that I found in all my years of doing this that works. Surgery on the disc, either a fusion, sometimes an artificial disc will work. Of course, the Deuk laser disc repair is the best. That's what you're seeing today. Okay? So surgery is necessary if you want to get rid of your pain. Now, we don't operate on people who have back pain that started yesterday. We want to give their back a chance to heal on its own. We only operate on people that have had chronic pain that doesn't go away on its own. Now, I need the shot. I need the knife. So the people that come and get surgery are ones who've had pain for years. You don't have to wait years, though. Thank you. And we're not going to make you wait years. Other surgeons, you'll either make you wait too long and suffer, or they'll tell you they can't fix your problem at all. Okay? There's only a few of us that actually understand that herniated discs are the cause of back pain and neck pain. And therefore, they should be treated expeditiously before the patient gets worse. And why suffer through pain when you don't need to? So there's this huge this dichotomy right now in spine care around the world, where 95% of spine doctors say, we don't know what's causing your pain, but you don't need surgery. Okay? And then there's a small number of us that understand the pain comes from the herniated disc. And then there's Deuk Spine Institute that understands the pain doesn't just come from the herniated disc, it comes from a tear in the back of the disc. And that's why this patient's here, is because she's witnessed me doing surgery before and curing people's back pain with the laser. All right, that's what we're going to do for her. Questions, Diego?
Yes, we have one question.
Yeah.
From your experience, which level causes the most pain and why?
Shot. All right, I heard just the beginning. From my experience, which level causes the most pain
And why?
and why?
Yes.
All right, so the answer I would give you is that the level that causes the most pain is L4-5, and it just does. It's the most common to be symptomatic from a herniated disc. Hands down, no doubt about it. L4-5. The second most common disc in the back to cause pain is L5-S1. And the third is L3-4. So it goes L4-5, L5-S1, L3-4, L2-3. L4-5 and L5-S1 are by far the most common. They account for 90% of back pain, chronic back pain from a herniated disc.
How
Mark
about
Stern.
cervical?
Why is that? Great question. Well, I believe, number one, they're the most common to be injured. Like when you look at people's MRIs, L3-4 is not injured as often as L4-5 and L5-S1. Well, why is that? Because of the biomechanics of the spine. It's basically the way that God created our spines, the way they're curved. The curves occur most pronounced through the L4-5 and L5-S1. They're also the discs that have the most weight on them, okay? So every disc you go further down your spine has more weight. Shot, take. Does that make sense? So the further up your spine you go, the less weight on those discs. But every disc that's further down has more weight added to it than the disc above it. It has all the weight of the disc above plus more. So just the way the spine is curved with lordosis, the fact that this is the two discs that get the most weight, and they're also probably the most mobile based on their anatomy of the facet joints. And they're also right above this very rigid part of the spine called the sacrum. So whenever you have a joint next to a very stiff part of the spine, that joint typically gets more wear and tear. So what I'm getting at is it's multifactorial as to why L4-5, L5-S1 are the most common to be painful, but it has to do with them being the discs that carry the most weight at the bottom of the spine. Plus, because of the curvature of the spine, they're most likely to be injured. Plus, they're also the most mobile discs. Plus, they're right above the sacrum, which is a stiff segment of the spine, doesn't move. So they absorb all the movement there. So I think it's a combination of things. I don't think there's one answer. All right. I need to see up there. So we are now inside the L3-4 disc, and that's what you're seeing. And that's not a normal disc right there. It looks like crab meat, and crab meat is how we describe a disc that's injured and that has had scarring and inflammation. It looks like crab meat. So I didn't make that up. Other people did. Flynn, come on in. How's she doing? So here's the laser, and the laser is going to start doing its job of basically debriding the annular tear. This is the annular tear, and the laser does a really good job of cleaning it up. The laser delivers energy. And of course, this blue fiber is not the laser. The laser is really a vague term, but what it means is we're referring to laser energy. And laser energy is energy, like all other forms of energy. It can be delivered to a specific mass. And that mass that we're delivering it to, watch that, is this disc. I'm delivering laser energy to parts of the disc that I want to repair. Now I'm not treating the whole disc, I'm just treating a very small area of the disc. Just for reference, that tube side to side that you're seeing is the tube that we're working through. That tube is 7 millimeters on the outside, one side to the other. So the internal diameter of this tube is actually around 6.3 millimeters, 6.3 millimeters. That's almost just less than 6.5 millimeters. So side to side is 6.5 millimeters. The fiber, the blue fiber, is about 1 millimeter, and the glass tube right there is 0.5 millimeter side to side, 0.5 millimeter. So this glass fiber is 0.5 millimeter, and the laser energy is created by a machine here in the operating room at the foot of the patient. You want to show them that machine? I think you have a path.
Yes,
Go towards the feet. Go that way, and you can see it right there. It's a giant machine. Move back. Step back.
Okay.
You see the machine?
Yep, I'm showing them right now.
All right. You can see how big it is. It's huge. It's a big machine. And it generates anywhere from 10 to 100 watts of energy per burst of laser energy, per burst. And I'm just taking those bursts and directing them from that machine, I'm transmitting that energy along this glass fiber all the way down into the disc. And not the whole disc. I'm not bombarding the entire disc with laser energy. Literally, the energy leaves this 0.5 millimeter wide tube and it goes out 0.5 millimeter. So it's a 0.5 millimeter by a 0.5 millimeter pulse of energy. Every time you hear the and it's at what, 15 hertz? Is it 15 hertz? Huh? 15 pulses per second. 15 hertz. This piece of herniation. Come on, get out of there. It'll be difficult with me. Ah, you're kidding me. What do they say? People should know when they're beaten. A disc herniation should know when it's beaten and not continue to give me a hard time as the conqueror. Right? Anyone know what movie that's from? Wow. Nobody knows? People should know when they're beaten. What movie? Huh? Oh, I thought you said you knew. Well, we'll give our audience a chance. I know everybody can use Google nowadays. I'll just give you a hint. It's from the Roman Empire.
Is that Troy or no?
Gladiator.
Oops.
Who said that?
That was
Rita,
me.
good job. Yeah. No. All right. And there's truth to that, right? So there's the tear right there. That blue stuff, the blue is the blue dye we put in. And that blue dye only binds to, only sticks to, only covers nucleus pulposus. That is abnormal and degenerated. So think about that for a minute. If you see blue, it must be the jelly from the center of the disc. And look at this. This is stuck inside the annulus fibrosus. These white fibers are the torn annular fibers. And why is there nucleus stuck in there? Look at it right there. It's stuck in there, causing pain and inflammation. And that's what I debride, clean out, defeat, conquer. Oh, God, Flynn. I'm just kidding. You know I'm going to have to mess with you a little bit, Flynn.
Yes, sir.
Okay? Because you're just in training, starting out, I got to mess around a little bit. We do that to all the new initiates. Any questions from our audience?
No questions. Just somebody
All
saying.
right, why don't you run the animation then on how the Deuk laser disc repair works to repair the annular tear and debride the herniation out of there.
The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, Submit your
Three,
MRI
two,
for a
one.
free review at www.
All right, so basically while you guys were gone, we discovered what's causing all the flashing. And I don't know if you saw it, but there's the other needle from the other side right there by the laser tip. You see that? And so that needle, we put it on the opposite side at L3-4. And that was just the laser energy being delivered to that needle. But this is the annular tear right here. And that's what we're debriding at this time. So I'm pulling my tube back and I'm cleaning this tear. This is where all of her back pain is coming from. And a lot of her leg pain. This tear right here causes the back pain. And if you have a herniated disc in your neck, it's going to cause neck pain as well. So herniated discs cause pain in the back or neck, wherever they're located. They can also irritate the nerves that are just next to the disc and run past the disc going down the arm or leg. And by irritating the nerve roots, people get arm pain or leg pain. And they can get numbness, tingling, and weakness. Numbness, tingling, weakness. No. All right, well. Any questions from our audience?
Yes, we have one question.
Stand
do
by,
you-
laser.
Do you have any recommendations for hip surgery?
Wait a second. I honestly could not hear that.
Can you hear me better now?
I couldn't hear that question. It's something about hip surgery.
Yes. Do you have any recommendations for hip surgery? We
I-
have somebody that says they have a lot of.
Diego, you got to speak louder. Turn up your volume. I just heard something about, do you have any recommendations for hip surgery?
Yes, we have.
Like-
We have somebody who says they have a lot of pains in their hip. Do you know?
Yeah.
Yeah.
Yeah, let me address that real quick. So, I am not a hip surgeon. I'm not a hip doctor. I mean, I may be cool, but I'm not hip. So, the reality is that I don't know the right answers about hips and hip surgery. I couldn't tell you. If you're asking for a recommendation of a hip surgeon, I don't have one that I would just straight out recommend to you. I think that there's a lot, I don't know enough about hips, okay? There's a lot of really interesting developments in treatment of hips, and I know I have my own hip problems, but the one place that I may check out, I would go based on recommendations from people I know, but I know that the Andrews Clinic, and I have no affiliation with them at all, but I know that they're pretty good, Dr. Andrews, but I don't know if he's, one of the best or not. Still, I think he's getting close to retiring if he hasn't already retired. I guess what I'm saying is I just don't know the right answer for hips. I don't want to mislead you or misguide you. So I'm not really the right person to ask. I'm sorry. We don't have a hip surgeon here. And honestly don't know who's doing cutting edge hip surgery. Like I do cutting edge spine surgery. I don't know who my equal is in the world when it comes to hip surgery. And truthfully, we have an international viewership, people all over the world watching the surgery, so there may be good surgeons that do hip surgery in your own country where you are. I just honestly don't keep up with it. I don't know. By the way, these are all pieces of herniation that are, around the tear, around the disc, the herniated disc. And what you can tell is that there's clearly a lot of damage to this disc. But that doesn't preclude us from repairing it. We can still repair it no matter how much damage there is. I've repaired the most damaged discs there are. Complete disc collapse. Where there's really no disc left. And you can still repair those discs. And you don't need to fuse. You don't need to put anything in there at all. Just go in there and get rid of that annular tear. You can't twist it. Okay, you can't twist it. Here, let me have that. Put your fingers in there. Here, grab it. Have you played with that yet?
A little bit, sir.
All right, good. So now if I take it from you, is that going to work?
No.
So how do you have to take it? That's right. You got to do the same, okay?
Okay.
You can't twist it off my finger. It won't work.
Makes sense.
I know you're just learning. Today's your first scrub tech day, or second. But a really good scrub tech thinks about everything.
Yes, sir.
And I love this story. Anybody remember the story of Dr. Roten's scrub tech, his best scrub tech?
You see this tension?
Did you hear it? You weren't around, Rita, were you? So, who's Dr. Roten and what am I talking about? Dr. Roten, Albert Roten, was the chairman of neurosurgery at the University of Florida in Gainesville when I was there as a resident. He's the one who accepted me as a resident in neurosurgery and trained me. He was one of my attendings. He's also a world-class neurosurgeon and famous all over the world for many things in neurosurgery, but specifically neuroanatomy and something called the Janetta procedure, which is a microvascular decompression for trigeminal neuralgia, and pituitary tumor surgery, where he went in and took pituitary tumors out of people's brains, and something called the radiofrequency, a Gasserian ganglion radiofrequency ablation, RFA. Basically, denervating or deadening the trigeminal nerve at the Gasserian ganglion to treat trigeminal neuralgia. Okay? So, it's funny because he actually treated pain himself.
You can leave it.
Anyway, Dr. Roten was literally a maverick in neurosurgery. He's dead now, passed away. But there's a story about his favorite scrub. And a scrub tech is the person you see in the movies standing there handing the surgeon instruments and assisting the surgeon. Luis is my scrub tech. Luis is a top-notch scrub. I mean, he's just like the person I'm going to tell you about in this story. He didn't start out as a scrub tech, but he's become one of the best there is. Not the best that I've ever worked with. Okay? So Dr. Roten, this chairman of neurosurgery at UF, had scrub techs, and Dr. Roten is was an incredibly detail-oriented person. Like, my staff think that I'm too detail-oriented. I pay attention to all the little details. But Dr. Roten was worse than me. I mean, better than me in many ways. So, but he was a total detail-oriented person.
So you see now this one.
So it's very hard to make him happy, very hard to please him. So since he was the chairman, the School of Medicine was trying to get him a really good scrub to help him in the cases in neurosurgery. And they kept trying scrubs, and nobody could actually do a good enough job to make Dr. Roten happy. But Dr. Roten would operate at all kinds of hours in the operating room, basically lived there. And he started to notice that his operating room was very clean, very, very clean. And he really liked that. He likes cleanliness. And he noticed consistently the operating room was clean, 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 and very organized and put together. So he realized the person responsible was the janitor. And the janitor was a gentleman named Fred. And Fred was cleaning Dr. Roten's room every day and doing an amazing job that Dr. Roten himself noticed. So Dr. Roten got to talking to Fred one day and said, "How would you like to scrub for me?" The janitor, right? And so Fred said, "Sure, I'd like to learn." So they brought Fred in and started training him. This is the janitor, remember. The guy who comes in and mops the floors. And it wasn't long before Fred was basically out scrubbing everyone else in the department. I mean, he was literally the best scrub. So when I got there in '97, Fred had been there for like 15 years as Dr. Roten's personal scrub. And the guy was a maverick as a scrub. I mean, He was on everything. There's nothing that happened in the operating room that he didn't know about. If a mouse farted in the corner of the OR, he knew. He knew the name of the mouse, and he knew exactly how long the fart was for. I mean, he knew everything about the OR. And everyone started going to Fred and asking for Fred's help, you know, scrubbing for the other neurosurgeons and helping them. So Fred became the head of the entire neurosurgery scrub department. He was the top scrub of all the scrubs. He was in charge of training and organizing and everything. And he finished his career when Dr. Roten retired. He retired. So I just thought you would enjoy the story, but Fred never wanted to be a scrub, but he got chosen because of his attention to detail, his commitment to high quality work, dedication. So I'm a big believer in tapping into people's potential and training them for things that perhaps would be a great fit for them, even though that wasn't what they started life out as. I like to elevate people, give them an opportunity to do better for themselves and their environment and their community. So in that note, we have Flynn here, who was never dreaming of being in the operating room doing surgery just a couple of months ago. He was thinking about the beach, the surf, the surf bunnies, and heck, he was in California, 3 months ago, right?
Yes, sir.
And here he is today in the operating room at Deuk Spine Institute, and someday I know he's going to be destined for greatness. Just like Luis. I found Luis. Luis was living in a cardboard box in the streets of Los Angeles. Right, Luis? I'm kidding. Luis came to us from Puerto Rico, and he's absolutely a superstar. He started out as an MA and worked his way all the way up to running our entire operating room and sterile processing department. So Luis is another example of really tapping into people's potential and giving them an opportunity to prove what they can do. I'm a big believer in that. I don't believe in pedigrees. I believe in proving oneself. So, all right. Do we have any more questions? Because we're just about done with this disc.
Yes. We have a pretty long question if you have time for
All right,
that.
give me a second.
Okay.
This is, once again, L3-4. We're on the patient's left side, and we're going to do the, I think, what should we do, Luis? Do we go 5-1, or should I finish the right side L3-4? Finish 3-4. Luis, no, we're going to do that. So we're going to switch to the other side of 3-4 in just a second. I'm just cleaning up the last of this interposed herniation. Okay? Coming back. Let's take a look. This disc was very badly damaged, by the way. I mean, massively damaged. Huge tear, huge herniation. You can just see how big it is. You can see how big the tear was on the discogram. It was ginormous. This is still some more herniated material, and we'll take that long question next. Go ahead.
Okay, so on Facebook we have someone asking about.
Again, you're just too low.
You can't hear me at all now,
I
or
can barely hear you.
how about now?
Much better.
Okay, so we have a patient. She has been avoiding spinal fusion for a long time, but she now has hip disease. She wants to know which surgery should she get first, hip or spine.
Oh, wow. I'm so sorry. I wonder if your hip disease has anything to do with steroids. Most people don't know this, and I should mention it because this is a teaching opportunity. A lot of people with back and neck problems get steroid shots, and what they don't know is that there's a condition. Look it up. Maybe you can type it up for them, Diego. It's called avascular necrosis of the femoral head, AVN of the femoral head. And what it is the steroids cause a reaction in the blood system and inflammatory system that can actually destroy your hip, like literally chew it up. And then you need a hip replacement. So is that what happened? I don't know. But I sure hope not. But it's something that people need to worry about when you have chronic back pain and your doctors are just treating you with shots. You know, I don't mind a shot or two, you know, to tie you over until you get fixed with surgery, but shots are never going to fix your problem. And surgery is necessary when, especially when it's a herniated disc causing your pain. Okay, so shots should only be used temporarily at most, and be careful, don't do more than say 2 a year, but
yeah.
it's something you need to worry about with that hip getting destroyed.
Yes, doctor, she's added, she says that she has had many shots of steroids in her life, and she has AVN doctors that don't want her to do surgery.
Oh yeah. All right, so she has AVN, I suppose. I don't know, is what it sounds like, right?
Yes, she has AVN doctors looking at her.
Okay, so she basically has, her hips have been destroyed by the shots, the steroid shots, for her back pain. So the question is, what should you do? I don't know how old you are, it doesn't really matter, but I would get my hips fixed with a hip replacement. 100%. If you want to have an active lifestyle, get your hips fixed. Should you get your hips fixed first or your back fixed first? Well, if you can get the Deuk laser disc repair, come get your back fixed first, and then deal with your hips afterwards. The hips are going to be a long surgery. It's going to be painful surgery. You know, it's hip replacement surgery. I think, you know, depending on who you go to, they may be able to do it less invasive, you know, just going anterior or something, but you need a good hip doctor and you need your back fixed so you don't have to deal with back pain anymore. And as a warning to everybody out there, look up AVN, avascular necrosis of the femoral head from steroids. It's bad. So try not to do too much steroid injections, folks. All right, we're done on this side. Yeah. Scope, laser out. Oh. I don't know. Did I answer the question, Diego?
Yeah, she says that what you predicted is her biggest fear.
All right. So we're going to do a little antiseptic.
She has another question.
Sure.
Can lower spinal disease cause problems with the function of the collateral system?
All I heard.
Colorectal system?
Oh, colorectal system?
Yes, yes.
Generally not. No, we don't need another one. Lower spinal disease usually doesn't affect the colorectal system, okay, by itself. But if you're taking narcotics, painkillers, it can mess with your bowels and your colorectal system. But it's very rare. I've actually never seen it where herniated disc, stenosis, unless it's like horrendous stenosis, like the worst in the world. And then again, I've never seen, you know, that stenosis that bad to where the bowels are affected. We need you in with the scope, fluoroscope. There's a condition where the herniation in the lower back or a tumor or infection can get so bad. I got it, because he's going to swing the scope up. It can get so bad, it gets so narrow, where the nerves called the cauda equina are pinched so severely. It can come from anything causing narrowing. Shot? Specifically, it could be, basically it could be a fracture, a tumor, infection, or a herniated disc, or even a foreign body that presses on the nerves. And you could lose control of your bladder. And, you know, it's possible, we're going 3-4. It's possible that you could lose control of your bowel, if that's what you're referring to, but in reality,
She's asking if any part of the spine affects the colorectal system.
does any part of the spine affect the colorectal system? I mean, yes, if you're paralyzed from your spinal cord being injured, then it can. Let me have a coker. So yes, you can. You can, but it's not usual. Shot? Yeah. I may need a second coker.
Can you open another blood tray or a coker, please? Thank you.
Just my luck.
Let me see.
Shot?
What you got there? Hemostat or what do you got there?
I think that's a first for me. Unreal. Shot? Unreal.
What do you think will happen? Smell?
Huh? Yeah, welded. Freaking the stylus has welded to the wall of the needle. All right. So I have to get this stylus out because it is literally stuck inside. Can you put pressure here?
Yes, sir. Yes, sir.
It's not stuck in the patient. It's supposed to slide out of the needle, and that's not happening. I'm going to have to come here. So fascinating. All right. Well, I may have to replace that needle.
Can I have another spinal needle, please?
Shot. Shot. No, I don't think you understand. Thank you.
Thank you.
No, I may have to take this one out completely and redo this. Oh, we got it. Thank God. All right, we got it. Shot. Perfect. Okay. Okie dokie. Go ahead. Thank you. I've never welded anything like that before. So, hey, do I get a certificate in welding now? Shot? Okay, there is the guide wire, and I'm going to leave the guide wire, take out this needle, and then we're going to... Looks good. Just barely welded. So it's just stuck. No big deal. We got it done. That's bad. All right. We're ready to get started on the other side at L3-4. Once again, incision. 7 millimeters. And we're going to come down with the dilator over the guide wire. And shot. Want to make sure I don't advance this guide wire in. Shot. Okay, that's good. Passing the facets. In the foramen, shot up against the herniation. You guys can see the herniation, right? Sticking out backwards. That's what's left on my side, the right side. right here, I can feel it. So I need to advance this dilator along the guide wire into the L3-4. Shot. Oh, any other questions? Shot.
All right, which the same patient says that she's not paralyzed, but she does use a cane with the AVN now.
Honestly, I just could not hear that.
You still can't hear me?
No, man. You
I have the full volume on now.
you got to spend some time as a radio DJ to understand what trail off means, but you got to keep your voice elevated till the end. Go ahead.
All right, well, the patient says that they are not paralyzed, but they use a cane now with the AVN.
Uh-huh.
They would not be getting any more cord decompression, and just says thank you for answering the questions.
Oh, okay. You're welcome. That's why we're here, to answer questions, to shed light.
Oh, okay. She's asking, does the doctor do cervical and lower in one surgery, or does he space it out?
Yeah, so someone's asking, can I do the lumbar laser endoscopic surgery the same day as the cervical? We'd prefer not to do that. It would be really unusual for me to do that. The reason is that they're two totally different surgeries. We want to make sure the patient recovers properly from one before doing the other. So I prefer not to do that. But I can do thoracic and lumbar the same day. That's thoracic disc herniations fixed the same time as lumbar. But I don't like to do cervical because you have to go basically through the front of the neck. It's a completely different positioning of the patient. It's with general anesthesia, they're asleep. And I really don't think it's a good idea. I would really not want to do it. I don't think it's good for the patient. I don't think it's safe. So to answer your question, cervical by itself and thoracic and lumbar can be done on the same day. All right, we're going back into the same disc we just fixed, but we're coming from the other side. And the reason we're doing that is because this patient had a herniated disc on both sides. And so I need to get in there and remove those herniations on both sides to unpinch the nerve. If she didn't have leg symptoms on both sides, I would have just done the one. But here's the herniation. Doesn't want to come out as one piece. Yeah, basically, it's a pretty good size herniation on this side. And I've shoved the herniation from the foramen, I pushed it in with the dilator. So this was developed by Dr. Anthony Young. Dr. Tony Young, one of my mentors in endoscopic spine surgery out of Phoenix. He taught me what's called the inside out technique, where you start inside the disc and you work your way out. And the reason why that's important is there are people who go outside in, and those people have a completely different philosophy about the treatment. And I don't think the outside in is safe. I think the inside out is much safer. All right, keep that away from my mask, okay? Who do we have here? Rita?
No, it's Crystal.
Crystal. I hate to trouble you, Crystal. No, that's fine. You can fix that, but it's more my skirt. It's kind of sliding down my skinny little hips. Sorry. Yeah, thank you. Oh, you're the best. One more tug and we'll be good. Okay, you're tightening it up? Yeah, that definitely helped. Thank you. So the skirt I'm wearing is from St. John, part of their fall collection. I'm kidding. I'm wearing a lead skirt, in case you're wondering. And the reason I'm wearing a lead skirt is doctors that work with radiation and surgery, like the X-ray machine, we need to protect ourselves, protect our staff. So we provide leaded things, like a leaded skirt, leaded vest, and the old lead from years ago used to be very thick, and it used to sit on your shoulders, and you'd have all that 20 pounds of lead on your shoulders. What you want to do is kind of keep it there. Yeah. And that 20 pounds of lead would just sit on the surgeon's shoulders the whole surgery. And by the end of the surgery, whoa, you got to give me a warning. By the end of your surgery, your neck was going to be killing. You need to see a chiropractor because the neck would hurt so bad from all that lead, 25 pounds of lead, being on your shoulders for hours. Okay? So the companies that manufacture surgical lead, which is the lead we use in surgery, they started to produce lead that protected your whole chest, abdomen and pelvis and legs, but they broke it up into two parts. Stand by. There's a vest that sits on your shoulders, and then there's a skirt that goes on your hips. And the other revolutionary change is that the weight of the lead, they started developing these ultra thin, lightweight leads that cannot do that. You need to let me take it from you, not release it with your finger until it's already in my hand.
We have another question.
Yeah, sure.
It's from a patient that has seen Dr. Patel for several years and received multiple shots and RFAs.
Yes.
He says that he's been listening to your comment about AVN. Should he be concerned?
Yeah, you should be concerned for sure. You're going to want to get your hips checked if you have hip pain. We don't just get MRIs and X-rays to look for AVN if you've had steroids. You have to have symptoms. You have to have hip pain. So if every person that had steroids got AVN, we would never be doing steroid shots because the risk would be too much. Nobody would do it. So it's not common, but when I see somebody who has a long history of steroid treatment and they have hip problems, it's something that I get concerned about. So if you've been getting steroids, and Dr. Patel, by the way, knows the doses you're supposed to get, and he's not going to over-steroid you like a lot of these other pain management doctors do. Dr. Patel knows the maximum doses that are allowed. So the people that are at risk for developing steroid-induced avascular necrosis of their hips are people that jump from doctor to doctor, go back and forth, see many different doctors, get shots from many different doctors. And so what happens is the dose of steroids they're getting, is cumulative. It adds up over time, basically. The effect adds up. And so they end up overdosing themselves on steroid because they change doctors that provide steroids. Okay, so if you're treating with one doctor who's really good at steroid administration, then you don't have much to worry about. Dr. Patel has never had a patient have AVN to my knowledge. So now the other people that are at risk is when you go to pain management docs that just do a lot of steroid shots. Radio frequency ablation and a lot of the procedures Patel does are not steroid based. They are temperature or thermal based procedures. Ones that deaden pain nerves, for example, like the RFA. There is no, it's not a steroid shot, it's a deadening of pain nerves. So there's no steroid, it's heat that's used. But If you're getting a bunch of steroid shots, then you definitely want to be concerned about it.
Yeah, that patient would like to add that they have not experienced any hip pain at this time, but they have had RFAs on both sides.
Yeah, but RFA doesn't cause avascular necrosis. RFAs are not epidural steroid injections. It's the steroids are generally like large amounts of steroids that are given with. Luis, what procedures use a lot of steroids that Dr. Patel does? Uh-huh. Like what about hip joints? Hip joints, like a hip injection. What takes the most? What procedure gives the most steroids? All right. All right. So, what I'm being told is, since I don't do this. Yeah, that's perfect. So what I'm being told by his staff is that he uses the same amount of steroids pretty much for all of his steroid shots, whether it's a major joint, large joint injection, or an epidural, or a muscle injection like a piriformis muscle. He'll use the same dose. And once again, Dr. Patel calculates those doses and keeps track of them for each patient. We have it in the chart. We know exactly how much was given. So he can make sure that patients aren't getting overdosed. What I'm saying to you, though, is that not all doctors are Dr. Patel. Most doctors that do pain management, in my opinion, are sloppy, and they don't pay much attention, and all they're thinking about doing is just getting money for that next steroid shot. So they're totally motivated to just juice you up with steroids like brining a turkey on Thanksgiving, all right? Whereas conscientious, proper doctors that practice good medicine and care about the patient's well-being, they actually are careful to calculate the right amount of steroid dose to give you over time. So there's different types of doctors, and you got to avoid the ones that, you know, are too aggressive with steroid injection. And just in general, steroid shots are something you should try to avoid. You should get your back fixed like this, you know, get it one and done rather than keep getting steroid injections. There's so much misinformation out there regarding, you know, chronic back and neck pain, and that's what we're trying to clear up. Steroid shots, in my opinion, should only be given for people with temporary pain that's a flare-up, and normally they don't have pain. They just get that steroid and they're done. And then they don't keep getting shots. Or they need surgery, but they can't do it right now because they have, you know, work or a project, and they're not able to take the time off to get a steroid surgery. So they get a steroid shot to make them feel better for a little while. So hold them over until the surgery is done. And then the final category are people who have surgery and actually need the steroid as part of their surgery to reduce inflammation. So I don't know if that helps, but everyone thinks steroid shots are just benign, but they're not. We actually have a spine scams exposed where one of our patients went to yeah, why not? I'm going to say it, you know. They went to a place called Physician Partners of America. You know anybody that works there? Anyway, they went to Physician Partners of America, I think. That's the name of it, right? And they stuck the needle in her spinal cord. And it wasn't anybody in this room that did that. It wasn't anybody at Deuk Spine. But we have it on our Spine Scams Exposed. So go to our YouTube channel and pull up one of our Spine Scams Exposed, and it's literally a woman who went in totally normal with some neck pain, and the problem was she had spinal stenosis pretty bad in her neck. She had herniated discs, bone spurs, narrowing of the spinal canal, which is a surgical problem. It needs surgery. That's what I do. I fix those. Okay? She went to a pain management doctor, and they took her for a cervical epidural. When they put the needle in and injected the medicine, it went into her spinal cord, which is absolutely a no, 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 no. Okay? It's the same as putting your head in a guillotine and pulling the string to let the blade come down. You never do that. It's stupid. You're putting your hand in a garbage disposal and turning it on. It's like the worst thing you could do to a human being is paralyze them by injecting something in their spinal cord. Well, that's what happened. So she's not like in a wheelchair paralyzed, but she was in a wheelchair for a while paralyzed. She's made somewhat of a recovery, but she's not normal, and I just saw her yesterday, as a matter of fact, in my clinic. So she left them, obviously, because they screwed her up. So what am I getting at is epidural injections are dangerous. They have risk, okay? Everything has risk that you do, but if you're dealing with incompetent doctors, the risk goes up. And there's a lot of incompetent doctors out there. I hate to say it. A lot. I try to keep them away from our practice, but they're out there. And I feel for you all, having to deal with them. Yeah. So what does that mean? It means just be really careful with the amount of steroids you get, and you have to trust your doctor that they're doing things right. But it's always good to have that conversation with them, with the pain management doctor, and just say, hey, how am I doing with my steroid load? Have I gotten too much steroid so far? Can I get much more? Is it safe? They should be able to tell you. Ask them about your risk for avascular necrosis. Am I getting to that limit where I can have AVN? Am I past the limit? Where am I? If they look at you funny and say, what's that? Then you better run. Run for the hills. Get out of there. Every good pain management doctor knows what avascular necrosis is. Okay? And they have to be very careful on calculating how much steroid you're getting to make sure they don't put you at unnecessary risk of AVN. Almost done with this disc. There it is. 12 o'clock, we have the epidural space. A little bit of fibers of the posterior longitudinal ligament. This is the last of the herniation here on the patient's right side. Big, just for the record, this was a really big herniation with really big tear. Like you could drive a bus through this tear. Okay? And I've been sitting here blasting it for a while. Why am I getting bubbles? Do we add carbonated water to the irrigation? Is it 7-Up? Can I get some cherry sauce and huh? No, I'm just getting a lot of bubbles. I don't know why. Well, we're pretty much done. We're pretty much done with this disc. I got to come back over there. You ready, Jordan? 30 seconds. Now this patient traveled to see me from Washington? No, New Jersey. Sorry. Yes. No. She's from New Jersey. Yeah, so this patient's New Jersey. The last one was Seattle. But this patient has researched her care over the years. She's had some top spine surgeons that do endoscopic surgery take care of her. One of them was Dr. Young, Anthony Young, one of my teachers, my mentor, one of the most respected surgeons I've ever will respect and appreciate his work and his teaching. He's retired now, but he's a true pioneer, true leader, an amazing man, an amazing doctor, and very, very special. So he taught me a lot about lumbar. All right, there's some fat there, but otherwise it's looking good. I'm happy. Scope off. All right. So we just finished the bilateral L3-4. How's our patient doing? We're just putting a little antiseptic in. It's antiseptic developed right here on the Space Coast of Florida at NASA called betadine. And we've talked about it a few times. It's what NASA developed to fight off the microbes from space that the astronauts might bring back with them. Invasion of the body snatchers kind of stuff. I think they must have watched the movie and figured we better develop something to make sure that never happens. How many people have seen the original Invasion of the Body Snatchers? What a great movie. I think I saw that when I was probably 5 years old. Made a heck of an impression on me. Incredible movie. It's unfortunate though that technology has advanced so much with movie making and cinematography today, because it's hard to appreciate a movie like that with today's cinematography. But back in the day, back in the 70s and early 80s, a movie like that it would draw you in to the storyline, and it could really manipulate your emotions during the movie, just with the great plot. And you had to use more imagination, but that was all part of it, right? What's wrong with using your imagination? Okay, we are at L5-S1, left side. We're going to be removing the needle.
Wait, what's next? Alright.
It's okay. He's doing good. Luis is so funny. He's so demanding. I'm kidding. Luis knows I'm demanding, but I've chilled out a little bit over the years because Luis does such a good job that I don't have to say anything anymore. I can just, do my thing. Be a surgeon. Shot. Luis takes care of everything else. But he set the bar high for you.
I agree.
You'll get there. As long as you stick it out. All right, we are entering the foramen at L5-S1. I'm going to pull the guide wire back a smidgen, just because I don't want to pinch it and advance it. You can actually do that accidentally. You can get a pinch going on between the tip of the dilator and the guide wire, and they'll move forward together. Normally the dilator slides along the guide wire, right? Normally the dilator slides along the guide wire. Shot. But in some people, it doesn't happen that way. You get a pinch and they slide together. Shot. Take. Shot. All right. All right, so this is a tough one. I don't want to advance this dilator anymore, so let me have the dilator grabber and pull it back just a little bit. Shot. That's better. Shot. That's better. He's fine. Shot. 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 Let me get that. Thank you, Luis. Why don't you close the other side?
Yes, sir.
All right, we were able to do both discs on this side with one incision. Everything okay, Jordan? So we were able to do both discs with one incision on this side, which is good for the patient. All I can say is these are some pretty bad tears. Yeah. Laser. Where's my pedal? Oh. We're going to be done in 5 minutes. This is a quickie. All right, we're going to be done soon. So if you have questions for me, feel free to ask me. One thing people think is that this surgery makes the disc back to normal. It doesn't. I was talking to somebody about that the other day. The discs never look normal again. Once you've damaged your disc, it'll never look normal again. We're not here to make the disc look normal. We are here for one purpose, to get rid of the pain. And we can do that without making the disc look normal. I don't think there's any way to make the disc look normal again. Not today, unless you take your disc out and you put a cadaver's disc in there, a dead person. A perfectly normal disc from a dead person, which I know it's being done experimentally, not in the United States, and honestly, it should never be done. It is so bad. Number one, the surgery, you have to hack through the vertebral body. Right then and there, it's an anterior approach through the belly, very dangerous. Second of all, you literally have to put the person on immunosuppression because you've just done a transplant. You're transplanting one person's body part into another. And that's always bad. You know, it always brings totally needless. There's absolutely no reason to do it. Look at this surgery. We can fix people's pain by just using a tiny laser and an endoscope. You don't need to take the whole disc out and replace it. There's no benefit to that. And to be on immunosuppressive therapy, yeah, I am totally against it. Yes, Diego?
Yes, doctor. We have a question from Facebook. They say that does this surgery limit you from weightlifting exercises?
So the question is, does this laser surgery you're watching limit you from weightlifting exercises? The answer is no. And I'm going to qualify my answer. So you cannot go back to weightlifting exercises for 1 year. I mean, you can go do light stuff in the gym, no problem. You know, lifting barbells, things like that, lightweight, 40 pounds maximum. But if you want to get back to heavy lifting and contact sports like football, rugby, you need to wait a year after your surgery before you go 100% to normal heavy lifting, okay? So in that first year, you can do some light lifting. But you got to wait a year to 12 months anniversary from your surgery. Otherwise, you're going to injure your disc and you're going to have to come back and have another surgery. And unfortunately, there are people that that don't listen, and they injure their disc, and they come back and have another surgery. That's 1%. 1% of my patients, 1 in 100, injure the disc again because they do too much too soon. But once you get to a year, you can do what you want. You can go bungee cord jumping, you can go skydiving, you can become a paratrooper in the military, you can do whatever you want. You can be a WWE wrestler. Okay? But you can't do it right away. You have to be reasonable. You have to give your back or neck a chance to heal. 30 seconds.
We have another question.
Uh-huh.
This one comes from YouTube. Let's say that the patient is in his or her 50s. Can they go back to work, and when?
Yeah. It doesn't matter how old you are, folks. With this surgery, you can go back to work in one day if you want to. The next day. There's no reason you can't. And you have to be careful with lifting. You don't want to lift over 25 pounds the first 6 weeks after surgery. Then it goes to 40 pounds for the rest of the year. Okay? But everybody that has this surgery goes back to a normal lifestyle, usually 1 year after surgery. Antiseptic? Antiseptic? What are you doing, a dance over there? The hand dance? Did you finish your closure or not yet? Alright, just let me have that stuff and I'll do it. You take care of the closure. Don't worry about me. Okay? Just give me all my toys. All right, so folks, Deuk Spine Institute has an app. You can go to our app store and download our app for free. And there's really good information in there. Also, Deuk Spine Institute has a Facebook page called the Spine Surgery Support Group. Spine Surgery Support Group. Feel free to go to the Spine Surgery Support Group and basically ask to join, and we'll let you in and you can ask questions and we'll answer them for you. All right. Pressure. I got it. Come over here. Are you still sterile then? Yeah, still sterile. Come on, get here. Put your hand here and put pressure. You want to put about that much pressure. Okay? Good job, everyone. So if you have more questions, I got a Ray Tech off the field. If you have more questions, feel free to type them up right now. Well, once again, check out our Spine Scams Exposed on YouTube at Deuk Spine Institute. No complications. EBL 2 mil. This was a bilateral. L3-4, DLDR, and a left L5-S1, DLDR. Check out Spine Scams Exposed. It's some interesting information. Sorry, everyone. Didn't mean to scare you. And we got one more surgery. What is it, a 2-level? No problem. All right, so that will be next. But go ahead and type up any questions you have for Dr. Deukmedjian and me, and I'll be happy to answer them for you. I'll be there in just a moment. Why don't you run the fusion versus laser comparison?
It's all natural. Are you glad you did it?
100% glad I did it.
Yeah.
I tell this story all the time. Everyone goes, oh my goodness, you had back surgery. Are you okay? I can't believe, how are you walking around and you look so comfortable? And I tell them, I don't have anything in me. and I tell them how the surgery went, and I don't mind showing them the video, and they're blown away. And so I often share your website and number with many people.
Thank you. Dr. Deukmedjian here with one of my patients who actually happens to be a musician and is here in the local high school, right? A very large high school for that matter.
Yep, absolutely. Largest in the district.
Largest in the district. And you have how many members in the band?
160.
160 students in the band, and he is the director of that program. Tell me about your back problems before we did your surgery.
I was an active runner and exerciser, and I was out, you know, on a very long run, 15K, and I noticed a pain running down my leg. I thought it was due to poor stretching and not enough stretching, so I increased that. It wasn't going away, which was a red flag indicator, and I saw my doctor, who then recommended an MRI to see what was going on. And it showed the herniated discs, the L4, L5, L5-S1, who then recommended me to go to another center to receive you know, back surgery. To which, and I had told you before, my wife saved the day and found you guys.
They usually do. The wives usually do. They keep us out of trouble.
Yes, she often does. So, you know, when I came to see you with that same problem, with the pain shooting down my leg, I would say at days, 9 out of 10, I would have to call off of work, sit at home, or lay at home, honestly, just to stay off of it, because the pain was so great.
Yeah.
Yeah.
So it really had, the pain in your back and down your leg had a really bad effect on the quality of your life and your ability to do your job. And what did the other center, by the way, what did they recommend in terms of treatment for you?
A fusion.
A fusion, right?
Yes.
So you didn't want a fusion.
Absolutely
You didn't want
not.
a fusion. You didn't want to lose the natural movement from your lower back. And you found out, your wife found out about our laser surgery, which preserves movement by not fusing. And we don't put anything in your body and leave anything in there. So your back pain that you had before surgery, which was done 6 weeks ago, by the way, how much of that pain do you still have?
0.
Gone.
0.
Cured.
Yes.
Awesome. And the leg pain?
It is gone. Yeah, the pain shooting down my leg has completely gone away, and it is wonderful to be able to climb the bleachers in the stadium, to get on my podium, and to be able to play my saxophone comfortably.
Awesome. Well, congratulations. You had the courage to do the surgery and have the laser surgery repair your disc, and here you are 6 weeks later doing fantastic. Please tell your wife, give her my best regards. Okay?
Thank you so much.
All right.
Hello everyone, thank you for sticking by. Dr. Deuk is on his way to answer your questions for the post-op Q&A. Please stay tight, he is on his way. Thank you very much.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross-links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time.
Hello there, Dr. Ara Deukmedjian, back with you. We just finished up here a surgery that is a Deuk laser disc repair. It's kind of a funny name, but what it means is it's Deuk as in Deuk Spine Institute, and my name, Deukmedjian, because I'm the one who pioneered the treatment. Laser, because we use a laser during the surgery. Disc, because we're actually working on a disc, which is a cushion between two bones called the disc. And repair, because we're repairing the disc, not removing it, not fusing it. Other types of spine surgery that involve the disc frequently involve removing the disc and replacing it with a cage and screws and rods. This is a fusion. Or replacing it with an artificial disc made out of metal. We're not replacing the disc with anything unnatural. We're taking the disc and repairing it. Basically just fixing the small area in the back of the disc that's the cause of the pain. Why do other doctors not do that? Two main reasons. One, they don't know how to do the surgery. And number two, they prefer to do fusion surgeries than artificial discs because those surgeries, honestly, they just pay more money than the laser surgery does. So they make more money for the surgery. I would think the vast majority of those doctors don't do endoscopic laser surgery because they don't know how. They were not taught to do it. There's an old saying, from the cradle to the grave. And what it means is what you're taught early in your what are called impressionable years is what you carry with you to the day you die. And unfortunately, you've all heard the old saying, you can't teach an old dog new tricks. It's the same thing. What it means is that during the 6 or 7 years that a surgeon is formed after medical school, that's in a process called residency and fellowship. Surgeons are basically trained to do surgery in those 6 or 7 years. And it's very intensive. It's 110 hours a week of work, and you're just totally focused on patient care during that entire time. I went through it, and I was taught to be a fusion surgeon, just like everyone else is being taught today to be a fusion surgeon or an artificial disc surgeon, okay? So I was taught artificial disc, fusion, and then laminectomy, microdiscectomy. So it wasn't until after my training that I learned about endoscopic surgery and that there was even such a thing. So unfortunately, the truth is that 99% of spine surgeons are not exposed to endoscopic spine surgery during their training. They have no idea it even exists. I didn't, and when I saw it for the first time, it was shocking for me to see it. It was quite an eye-opening experience. Sorry about that. Dr. Deukmedjian. Yes. Sorry. Sorry about that. So the key is the training. And, you know, until surgeons are trained during their residencies to do endoscopic spine surgery, there's going to be very few that know how to do it. Like literally out of worldwide, say 50,000 spine surgeons, there's going to be quite literally 50 that are proficient at doing endoscopic surgery. And so we have to change the culture. We have to change the universities and how they train neurosurgeons and orthopedic spine surgeons. And the problem is that there is a vested interest by companies that manufacture screws and rods and cages. This right here alone is around $15,000 worth of metal. Or they manufacture metal plates for the neck or screws and rods. These companies are controlling our education at our universities. They're invested in the university, and they're controlling what's being taught, what's being done to patients worldwide. And that has to stop. It's not in people's best interest anymore. It used to be a long time ago, but now we have laser spine surgery. We have surgeries like the Deuk laser disc repair that you just watched. And these types of surgeries are far less invasive, much faster recovery, safer, and have better outcomes. Thanks for hanging out with us. We got one more surgery to go. Oh, one question? Go ahead.
What would you typically do to repair an unstable burst fracture at L3 vertebrae?
What would I typically do to repair an unstable burst fracture at L3? L3 is 5-4-3. So this is where the vertebral body is cracked and it's unstable. The fact that it's unstable means it has to be treated. And for that type of a fracture, what I would do is I would do a fusion from L2 to L4. I would put screws and rods, L2 to L4. I would decompress the nerves at L3 if they need to be decompressed with a laminectomy. And I would tap the bone fragments from the back forward and shove them back into the L3 body. So there's nothing pinching the nerves. If there's no neurological deficits, I would leave it alone and I would just do a fusion from L2 to L4. Now, when I say fusion, what I mean is I would put screws at L2, screws at L4, above and below the L3, and hope that the L3 will heal itself and fuse itself. And then you could even take the screws out a year or two later. All right, thanks for the questions. We'll see you for the next surgery. Thank you.